Welcome everyone. I'm Ben Osevwe, DNP-PMHNP-BC from Solly Foundation Psychiatry and Rotation Match Network. Today we're tackling major depressive disorder, or MDD. Everyone thinks they understand depression until they realize it can mimic bipolar, grief, trauma, or burnout. That's why this lesson is vital. MDD is a leading cause of disability worldwide, affecting over 280 million people globally and placing a massive burden on our healthcare systems, families, and workplaces. As PMHNPs, we are the front line for evidence-based care, identifying these symptoms early and providing life-saving interventions that restore function and hope. Our role is not just to prescribe, but to provide a comprehensive management plan that addresses the biological, psychological, and social dimensions of this condition. In the next 12 minutes, we'll cover MDD assessment, diagnostic criteria, differential diagnosis, medication profiles, and a real-world case study. We'll explore the biological and psychosocial factors that contribute to this complex syndrome. By the end, you'll feel more confident in your clinical reasoning and treatment planning for this fundamental diagnosis. Quick disclaimer, this video is for educational purposes only. It is not medical advice. It does not replace clinical judgment, supervision, or emergency evaluation, and it should not replace your organization's policies, state laws, or clinical practice guidelines. Clinical decisions should always be individualized based on the patient's unique history and presentation. For any patient with suicidal thoughts, homicidal thoughts, psychosis, severe functional decline, or inability to maintain safety, follow emergency protocols and escalate care immediately. Your priority is always the safety of the patient and the community. Major depressive disorder is a psychiatric condition marked by a persistent pattern of depressive symptoms that causes distress or impairment. The key idea is this: MDD is not just feeling sad. It is a biological, psychological, and social syndrome. A patient may say, "I'm tired, I can't focus, I don't enjoy anything, I feel like a burden, I cannot sleep, or I wish I would not wake up." These aren't just feelings, they are symptoms of a neurochemical and functional change in the brain. For PMHNPs, we must look beyond the word depressed. We assess the full clinical picture: symptoms, duration, impairment, safety, medical causes, substance use, bipolar history, trauma history, and psychosocial stresses. Answer: depressed mood and loss of interest or pleasure, also called anhedonia. A patient does not need both, but at least one of these core symptoms must be present when considering MDD. For a major depressive episode, we look for at least 5 symptoms over 2 weeks, representing a change from previous functioning. At least one must be depressed mood or anhedonia. Symptoms include significant weight changes, sleep disruption, psychomotor agitation or retardation, fatigue, feelings of worthlessness, poor concentration, and recurrent thoughts of death. Remember CGCAPs: sleep, interest, guilt, energy, concentration, appetite, psychomotor, and suicidal ideation. These symptoms must cause significant distress or impairment in social, occupational, or other important areas of functioning. They also cannot be due to substances or another medical condition. We must be diligent in our screening, as many medical conditions like hypothyroidism, anemia, or B12 deficiencies can present with identical symptoms. Furthermore, the episode must not be better explained by a schizophrenia spectrum or other psychotic disorder. Answer: bipolar disorder. Never forget this. Before starting an antidepressant, screen for a history of mania or hypomania. Treating bipolar depression with antidepressant monotherapy can trigger a manic episode, rapid cycling, or worsen mood instability. Clinical vigilance is your best tool here. A strong PMHNP assessment for depression should be organized. First, assess the chief complaint. Ask, what brought you in today? And what is the hardest part of your day? Second, assess symptom criteria using SIGCAPs. Third, assess severity and impairment. How is this affecting their life? Fourth, use measurement-based tools like the PHQ-9 to track progress. Fifth, assess safety. This is not optional. Ask directly about suicidal thoughts. Sixth, screen for bipolar disorder using tools like the mood disorder questionnaire. Seventh, assess medical and substance contributors. Think thyroid disease, anemia, B12 deficiency, or sleep apnea. Eighth, assess comorbidities like anxiety, PTSD, or ADHD. Assessment equals symptoms, severity, safety, bipolar screen, medical rule out, and functional impact. Let's slow down here, because suicide risk assessment is one of the most important PMHNP skills. Do not dance around the question. Ask clearly and compassionately. You can say, when depression becomes overwhelming, some people start having thoughts that life is not worth living. Has that happened to you? Then move to plan, intent, and access to means. Risk factors include prior attempts, current plan, intent, and substance intoxication. Protective factors may include children, family support, faith, and pets. But here is the clinical twist. Protective factors do not erase acute risk. If there is imminent danger, escalate to emergency evaluation. False. Asking about suicide opens the door for safety, support, and intervention. It shows the patient you are a safe person to talk to about their darkest moments. Now let's talk differential diagnosis. Not every patient with depressive symptoms has major depressive disorder. Number 1, bipolar disorder. If they have mania history, it's bipolar, not MDD. Number 2, persistent depressive disorder, which is chronic, lasting at least 2 years in adults. Number 3, adjustment disorder, which is a reaction to a specific stressor. Number 4, grief. Grief often comes in waves and is connected to loss, whereas MDD is more persistent worthlessness. Number 5, PTSD. Look for trauma exposure and hypervigilance. Number 6, substance-induced. Alcohol, cannabis, or stimulants can mimic depression. Number 7, medical causes like hypothyroidism, anemia, or vitamin deficiencies. Number 8, psychotic disorders. Differential diagnosis protects the patient from the wrong treatment. Now let's talk medication choices in more detail. This section is about understanding the why behind your selection. First-line SSR is like sertraline or escitalopram are staples due to their safety profile, but we must educate patients on common side effects like transient GI upset, sleep changes, and sexual dysfunction. Titration is key. Start low and go slow, but ensure you reach a therapeutic dose within a reasonable time frame. Fluoxetine, with its long half-life, is excellent for patients with poor adherence but can be activating. SNR is like duloxetine and venlafaxine target both serotonin and norepinephrine. Duloxetine is a powerhouse for depression with comorbid chronic pain, while venlafaxine requires careful blood pressure monitoring at higher doses. Bupropion is a unique norepinephrine dopamine reuptake inhibitor, making it ideal for the melancholic patient with low energy, but it is strictly contraindicated in patients with seizure disorders. Mirtazapine is our go-to for the frail or insomniac patient, providing sedation and weight gain, but monitor metabolic parameters. For treatment resistance, we look toward augmentation with lithium, thyroid hormone, or second-generation antipsychotics. Always consider the patient's prior response and side effect sensitivity when planning your next step and be vigilant for signs of serotonin syndrome when combining serotonergic agents. Medications are important, but they are not the whole story. Evidence-based psychotherapies include CBT, which addresses cognitive distortions, interpersonal therapy, and behavioral activation. Behavioral activation is especially practical for PMHNPs to teach. Depression tells patients, do less, isolate more. But behavioral activation says, start with small, meaningful actions, and mood may begin to follow behavior. Lifestyle interventions also support treatment, regular sleep, physical activity, and social connection. For severe cases, catatonia, or inability to care for self, always consider a higher level of care like PHP or inpatient. Let's apply this clinical knowledge to our case. Our 29-year-old graduate student has moderate depression with prominent anxiety and fatigue. Her wish to disappear is a passive death wish, requiring a formal safety plan and close outpatient monitoring, but not necessarily immediate hospitalization. When choosing a medication, we rationalize. While bupropion might help her fatigue, her prominent anxiety makes an SSRI like sertraline a more balanced starting point to avoid worsening her jitters. We start at a low dose, educate her that it may take 2 to 4 weeks to feel a change, and schedule a follow-up in 14 days. We also initiate a referral for CBT as the combination of meds and therapy shows the highest efficacy. If she had reported significant weight loss and severe insomnia instead, mirtazapine would have moved to the top of our list. This is the art and science of PMHNP practice, matching the pharmacological profile to the patient's unique symptom cluster while fiercely protecting their safety. Here are your final high-yield PMHNP pearls for the boards. Remember the black box warning. Antidepressants can increase the risk of suicidal thinking in children, adolescents, and young adults up to age 24. Monitor them weekly for the first month. Screen for postpartum onset if symptoms begin within 4 weeks of delivery. Know your emergencies. Distinguish serotonin syndrome. Think hyperreflexia and myoclonus from NMS. Adolescent depression often hides behind irritability and academic decline rather than typical sadness. In older adults, pseudodementia can mimic cognitive decline, but it resolves when the depression is treated. Never skip the medical workup. TSH, CBC, B12, and vitamin D are non-negotiable. And finally, your documentation is your best defense. Include your rationale for diagnosis, your explicit suicide risk assessment, and your collaborative safety plan in every single note. Clinical excellence starts with clinical curiosity. Major depressive disorder is one of the most common and clinically significant conditions you will encounter as a PMHNP. Your job is to assess carefully, protect safety, and choose treatment wisely, balancing evidence with the individual patient's needs. This is not just about prescribing, it's about building a therapeutic alliance and providing a roadmap for recovery. Remember our framework: symptoms, severity, safety, bipolar screen, medical rule-out, and treatment choice. This systematic approach ensures clinical excellence, diagnostic accuracy, and patient safety. Thank you for watching this educational video from Solly Foundation Psychiatry and Rotation Match Network. For mentorship, clinical growth, and educational support, connect with us at the Academy. We're here to support your journey from student to seasoned clinician. Continue asking strong questions, staying curious, and growing into a safe, confident PMHNP. I'll see you in the next session as we continue to advance our practice and improve patient outcomes together. I look forward to your growth.